Thank you very much, Chairperson Mohammed and Lady, for that wonderful introduction. It's a great pleasure to see you again. Always great pleasure to come to Cairo and meet all my friends again. Big thank you to Professor Ines Shaltut, as usual, and the organizing committee for this wonderful Congress, for the invitation to come and take part. So yeah, this title actually resonates with me, considering I'm originally from the low-income countries, East Africa. But first of all, just wanted to start off with this quote from the great man: "Of all the forms of inequality, injustice in health is the most shocking and inhumane." My talk is split into these sections. First of all, I've defined, for what I've read, what low-income countries are. Look at the epidemiology of diabetes complications, glycemic control and the challenges to achieve the targets, how we develop the infrastructure to improve diabetes management in these areas, and the initiatives that are worldwide now to try and help with the improved care, and then the future. We can discuss that perhaps in the discussion section. Here are 20 countries with the lowest gross domestic product per capita in dollars, and low-income countries are those that have a GDP of $1,000 or less, and then middle incomes will be 1,000 to 12,500 or more. And then the extreme poverty is defined as individuals living below $1.9 and struggling to meet human needs. So this is 2020 assessments, which showed that Burundi was the lowest income in this group, averaging about $280 per individual living there. The worst scenario is this, that when we look at complications, and this is data looking at the prevalence of microvascular and macrovascular complications in diabetes at diagnosis of type 2, and you can see in terms of retinopathy, diabetic kidney disease, neuropathy, myocardial infarction, ischemic heart disease, stroke, and diabetic foot, there are so many patients already having developed complications at the time of diagnosis. The worst scenario is this data showing deaths from diabetes before the age of 60, again mostly occurring in the areas of low-income countries, particularly those in purple, dark blue and purple, as you can see from this slide, round about 50% or more dying before the age of 60. We've already heard about obesity, and this is a striking relationship between these populations. You can see this is data published from the analysis of migrants in Ghana. They looked at migrants from 2012 to 2015, aged between 25 and 70, round about 5,600 people from these villages in Ashanti. Some of them had migrated to London, Amsterdam, and Berlin. And you can see from the top cartoon, the increase in obesity, the increase in diabetes prevalence compared to the rural population in green, and then those are urban Ghanaians in blue, and then the others are the ones that have migrated to the cities, and you can see the prevalence of diabetes is higher as they migrated to the cities. On the right-hand side in B are the females, showing similar picture of rising in diabetes prevalence. And at the bottom, you can see the mirror image of prevalence of obesity in these groups as they are migrating to more affluent type of lifestyle, suggesting environmental changes are responsible for what we already know is the problem with obesity. What's interesting is when they looked at South Asian migrants, this did not apply, suggesting that there is a difference in mechanism in the development of type 2 diabetes from these particular groups. And this is data from Chennai, New Delhi, India, and Karachi, Pakistan, and the US. And they looked at those groups, same groups in the US, to compare the prevalence of glycemia and dyslipidemia. And you can see that the South Asians men, there were 33% were affected, and 11% of the females were affected. But when you look at the US Asian men, this did not go up any higher than we had seen in the Ghanaian migrants earlier, affecting 15% of the men and 1% of the females, suggesting that there is a slight difference in the mechanism of diabetes development in this population. So let's just have a look at some of the problems in the low-income countries. This is data from Mali, Kenya, Mozambique, and Nigeria, but I've just shown you 3 countries there, looking at the prevalence of type 2 diabetes, availability of insulin. You can see in Mali there's only 17% when they published this in 2008. Mozambique, 20% had access to insulin, and Zambia had 75%. And you can see the cost, average insulin cost in public sector was $10.88 in Mali, and 1.13 in Mozambique, and $2 in Zambia. So Zambia seems to have done well, and I'll explain why later on. And this is similarly looking at other materials for diabetes management, and you can see presence of urine glucose strips, again 54%, 18% in Mozambique, and 61% in Zambia. Presence of ketone strips, 13%, 8% in Mozambique, and 49% in Zambia. Glucometers, similarly, shortfalls they are shown there, and the presence of spectrophotometers, glucose monitoring equipment, again, shortfalls as shown on this slide. And this is data published in 2021, looking at the state of diabetes treatment coverage in 55 low-income and middle-income countries. And you can see here a shortfall in glucose-lowering medications. Around about 50% had access. Antihypertensive, 40%. Cholesterol-lowering, very low levels, around 15%. Diet counseling, diet, exercise, weight loss counseling, low levels there. And pharmacological treatment, you can see shortfalls. And then if you take all the recommendations for for diabetes management, again, you can see that only around 10 to 15% had all the recommendations available to their population patients. The cost is astonishingly different. You can see here for Africa, in human insulin, pork insulin, beef, all insulins, in fact, are much more expensive compared to Europe, North America, and Southeast Asia. But I think the saddest slide I can share with you is this one. As you are aware that we have been celebrating 100 years of discovery of insulin, 1921, from Frederick Banting and Charles Best at the University of Toronto, discovered and extracted insulin. And here is a quote from the World Health Organization. From penicillin to insulin, antiseptics to anesthetics, and X-rays to magnetic resonant imaging, science has led to the dramatic improvements in health worldwide. It also cites the work of Frederick bunting as one of the discoveries that has, quote, revolutionized our approach to public health. And the problem, of course, is that 3 multinationals dominate in the insulin market. And here's the biggest worry from this slide. You can see, if you look on the right-hand side, life expectation at the age of 10 in 1922 in Boston, USA was around about 14.3 years. And when you go to life expectancy of type 1 diabetes between 1965 and 1980, and again you can see in Boston 68.8% life expectancy. It's 68.8 years life expectancy. And if you compare that to life expectancy at birth of someone diagnosed with type 1 diabetes between 1965 and 1980 in the countries in Mali, Mozambique, Vietnam, and Zambia are all below the expectancy as it was in Boston in 1922. So there is a problem here in access to essential treatment. And it does affect how control of diabetes is achieved. This is a meta-analysis of peer-reviewed journals, papers 2012 to 2022, round about 21,000 persons monitors. And you can see glycemic control throughout this region was around 30% on targets. So the suggestion is that we should have functional diabetes care systems, and this is a suggestion from Mesa et al. And you can see at the bottom here, integrated care is advocated, and enhanced medication, access to medication, appropriate research, task-shifted workforce, novel financing mechanisms, and more importantly, policy prioritizing control of diabetes. Do the integrated care systems make any difference? And of course they do. On the left-hand side, I've shown you a meta-analysis of around 110,000 individuals from 31 healthcare systems, where they looked at diet and exercise alone or both in preventing progression of non-insulin, impaired glucose tolerance to type 2 diabetes. Some of the data has already been shown in the earlier talk. And they followed these up for about around 6 years and looked at progression of glucose intolerance to type 2 diabetes. And you can see for the control group, there was 67.7% that progressed, diet alone 43%, and then exercise group 41%. But when you combine diet plus exercise, you can see a significant reduction to progression of 46%. And then if you look at on the right-hand side, this is data from Brazil, looking at, well, when you have the right infrastructure, you can actually achieve comprehensively reduction in cardiovascular events. And this is showing that case management, audit feedback reports, and distribution of educational materials to health professionals and patients compared to usual care shows that intervention clustered had a 3.4% incidence of the usual care had 3.4% compared to 2.6% in the intervention group, showing that actually integrated care systems have an impact on cardiovascular events. And if you do the same in the low income and middle income countries, again, this is a systematic review showing that if you follow up patients over a period of 3 to 4 to 8 months, there was a HbA1c reduction of 0.5 to 2.6%. So the other problem for the low-income countries is the problem that the guidelines that we are more familiar with are more applicable to the high-income countries rather than to the low-income countries. And so the WHO have actually modified some of the guidelines, and I'll read them out to you. So give a sulfonylurea to patients with type 2 diabetes who do not achieve glycemic control with metformin alone and who have contraindications, or the ones that have contraindications to metformin. Introduce human insulin treatment to patients with type 2 diabetes who do not achieve glycemic control with metformin and or sulfonylurea. If insulin is unsuitable, then you can use DPP4 inhibitors, and the others may be added. Use human insulin to control glucose in patients with type 1 diabetes. And then consider long-acting analogs to control diabetes in adults with type 1, type 2, who have frequent hypoglycemic episodes. So these are some of the initiatives to try and improve the infrastructure in low-income countries. This is the joint IDF and WHO called Rapid Access to Insulin, that has been introduced in the low-income countries. And I won't go into many details, but that's just to educate and provide the facilities that are required to control diabetes. And Zambia, as I showed you earlier on, was having more access to medications compared to the other countries, because it was one of the pioneer countries where this initiative was done. And to cut a long story short, by the year 2007, you can see availability of oral hypoglycemic agents and insulin improved within a few months of introducing the programs. And the life expectancy increased from 12 months in type 1 diabetes to 15 years, showing vast improvements in the provision. And these are the World Diabetes Federation projects that have already been launched. And this is what we are spending in the Western world compared to Africa, for instance. It's 12.6 billion pounds for the care of diabetes. And this is the kind of thing that we can do something about to improve care. The resource is there, and I recommend you to buy the stone from Tanzania. It's actually called Tanzanite, and you can achieve good profits if you bought that. But what I'm trying to point out with this slide is that there is so much resource within the continent, and what I don't understand is where it's all going. The Chinese have the right attitude, and they have put infrastructure as well as lending money to these countries, but they have mostly interested in energy projects, transport, metals, and estate development. And you can see at the bottom there of the slide is how much is invested in health and tourism. So, Mr. Chair, alarmingly, the prevalence of diabetes is exponentially increasing in the low-income countries. There's urgent need for wide implementation, effective interventions for primary and secondary prevention of diabetes in all communities. Establishing timely and effective integrated diabetes programs in these regions is required, but you need a shift in the current public health priorities and collaboration from World Health institutions, governments, industry, and the provision of affordable facilities. And to finish off, I leave you with a quote again. Many thanks for your attention.